Our next panel is regarding mobile applications, FHIR, and healthcare transformation, what you need to know. This panel will be moderated by Aaron Seib, who's the CEO of the National Association for Trusted Exchange, or NATE. Mr. Seib is passionate about health information exchange and has made the realization of a learning health system his professional life's mission and ambition since his son was diagnosed with autism in 2004. Mr. Seib is currently engaged with a number of projects that promise to take the nation one step closer to realizing this ambition. Ladies and gentlemen, Aaron Seib.
I am so happy to be back in Michigan. I think the person who introduced me mentioned that my son is on the autism spectrum, and I've shared many times with this audience how important it is for me to be part of the solution. I am very fortunate, very blessed to be involved in a project called the Autism Learning Health Network, which has been something that I see as a goal for a long time. I'm also very proud to be able to introduce several of the folks from our country, leading our country in innovating healthcare for consumer access. So I would just ask you gentlemen to step up, and then maybe I can introduce you as you have a seat. Mark Scrimshire is the entrepreneur in residence for the CMS Blue Button. His title is CMS Blue Button Innovator. We also have Gajen Sunthara, who is with Boston Children's. His title is Director of Innovation and R&D at Boston Children's. And we have Albert Culbertson, who's the innovator in residence at HIMSS. All three of these gentlemen have innovator in their title, and I think kind of hearkening back to Brian Peters' conversation about innovators or disruptors, I think innovators is a code word for disruptors. We are the people that are going to disrupt the entire healthcare system, hopefully, change how care is delivered, get the consumer more centralized to that care delivery, and change how care is paid for. So I'm very excited to walk away from that mic. And I'm not the most, I'm the least important guy because I'm like really dependent on them to make the things that I want to see happen for children affected by autism, to improve how we can reuse data that's gathered in the clinical and in the financial sectors to improve outcomes and improve how care is delivered for kids who are on the spectrum. So I thought it would be really, rather than me telling your stories, just to ask each one of you, how are you using FHIR and mobile apps and other technologies to enable that kind of vision that we all share? Mark, maybe, would you start?
Okay, do we have mics? While we're sorting things out. So, hi, yeah. So Mark Scrimshire, as Aaron said, Blue Button Innovator. So for the last couple of years, I've been working at CMS, and when you talk about disruptors, I actually describe my job as I'm paid by the US government to cause trouble inside the US government. And so what we've done is we have built an API based on FHIR, so this is one of the hot topics of this conference and many others, that has the data for 53 million Medicare beneficiaries, has 4 years worth of their claims information, and we're making that available really as simply as the beneficiary can log in on a smartphone, authenticate using their Medicare credentials, and click a button to authorize. And then they can share using their HIPAA right of access. So we're really trying to enable access. So one of the things I say to folks about this is when you look at, we've heard a lot about HIPAA and how the problems of sharing information, but the patient, the consumer, the citizen, is one person in the whole healthcare industry that can bridge the gap between covered entities and non-covered entities like community or faith-based organizations that may be delivering care in the community. And so if they choose to trust an application or a service or a research program, they should be able to do that. And that's what we've basically been doing at Medicare, is to make that available. And it was announced by SEMA in March at HIMSS, and we now have a half a dozen organizations actually live. In fact, Gajen's One Up Health, actually you said you went live this morning, so we're actually out there connecting people, and we have actually over 400 developers in our sandbox where you can come and play. I've talked enough for now.
Just, really I think a significant thing from the perspective of MyHIN and the consumer engagement, when we think about being able to reuse the Medicare claims file as an indicator of care that snowbirds have gotten in Florida. So we may be able to augment the amazing things that we're doing here in Michigan with data from CMS, contributed to the network by willing Medicare beneficiaries, that makes it less guesswork of what happened while you were in Florida. Something about your pancreas. Well, who did you see? What did they say? And we can sort of shorten the time for me as a physician to discover who was giving you care, what was the care about, and eliminate that kind of search pain point for a lot of docs in real time. Gajen, you want to share a little bit about how you're innovating and what you're doing at Boston Children's and also One Up Health?
Awesome. Thank you so much for the time and opportunity here. At Boston Children's, like one of the themes that we see here is clinical burden, and we have all these data. All the data is being pretty much coming from disparate data systems coming into our platform. How do we make sense out of the data? How do we make artificial intelligence to understand what this really means to minimize clinical burden for our providers? That's kind of the theme that I would love to kind of focus on, and as the previous speakers spoke about that angle as well. We have a demo, so we'll show you kind of demo towards the end. But overall, how do we understand our patient population? How do we understand these are the high-risk patient population that we want to focus first, and how do we enable technology in the inpatient room, in the outpatient setting, in patients at home, to gather all the intelligence data and reach out before any significant events happening to the patient. So we'll touch base on that. So that's kind of the focus at Boston Children's. How do we build AI to understand our patient population as we serve some of the complex care patients across the country, and how do we improve that care?
Great, Gaj. Yesterday, Carla Smith sort of preempted your appearing for us, Adam Culbertson. She sort of shared that he's figured out how to solve the patient matching problem using AI. So I kind of cue him up for that conversation, because I think before we can really start using deep learning and all of the artificial intelligence opportunities, we have to really be able to find a very confident way to correlate all the consumers' data from Florida, from Michigan, from Mayo, if they go to Mayo.
Yeah, so Carla set the expectations high, and I'll try to bring those expectations back down. So my name's Adam Culbertson. I'm the HIMSS Innovator in Residence, and so I actually had the privilege of working with these guys through the Innovator in Residence program. So Mark was an entrepreneur in residence. I'm a innovator in residence. Ask me later if you want to know what the distinction is. And Gaj was a presidential innovation fellow. So there actually is innovation happening in government. So they brought us in to, cause trouble and stir up ruckus, and turns out I was really good at that. So what I worked on is patient data matching, and so I always tell people it's asking the question, are these two things the same thing? So is John Smith the same as Jonathan Smith, the same as Jay Smith, right? And so matching is one of the fundamental core technologies that we have to really master if you want to advance interoperability. And so the relation to FHIR is, I said, okay, well, it's great, we could come up with great matchers, but you need to be able to get the data, access the data, and FHIR turns out to be a really great way to integrate matching solutions in there. So hopefully you're doing some future work around integrating an open source matching algorithm within the FHIR spec, potentially doing some standardization of the blocking, so that is the elements that we take in, so first name, last name, and how the system takes it, and then also spits a score back, right? So probabilistic matching basically says how similar two strings are, or how similar two sets of data would be. And so that's just a little bit of a tidbit. My work has been fundamentally with matching, trying to understand how good the current systems are. So a lot of salesmen will come and say, I've got the best matcher in the world. And I'll say, well, how do you know? And well, because I have a great slide deck, and so it turns out actually with matching we can measure these things, and so matching is going to be important for getting to AI, to doing good machine learning. If you can't do this, we can't really do anything downstream and have any confidence. And so a lot of my work is around the validation of the integration.
So I had the privilege to work with two of the folks here on my left, right. In the time frame I was at the ONC and the White House, in terms of Blue Button. And one of the things that we did was Mark took the initiative to the next level with CMS. But when I came back to my private sector, I started a company called One Up Health. At One Up Health, what we are doing is we have a three-sided market: app developers, providers on one side, and patients on the other side. When matching need to happen, when patient, in order to have a true longitudinal health records, we need to get data from multiple health systems. So what we currently doing right now, so we giving a patient, a user may have multiple patient profile on our platform, and we offload the matching to the users using FHIR. What that really means, I have 2 kids, and I have 3 patient profile in my account, and I select which patient that I want to bring the data from. For example, when I connect to my Stanford, when I connect to my Boston Children's patient portal, it will have a proxy saying, hey, which child account you want to have access to. So you offload that data, and the matching works to some of the stuff to consumers and patients. Let them take a little help from the matching perspective. And plus, FHIR provide very rich terminology coding behind it, a lot of metadata behind it, IDs from health system are behind it. So those are really awesome attributes that will enhance matching that Adam and the rest of the world is kind of focusing on.
And I think, Adam, the work that you're doing is really important when we don't have the consumer engaged, and especially for a lot of the trust frameworks that we have. It's very important to be able to support that. And it's based on trust, right? So there's a trust framework that enables us to address that. At this point in time, it seems like we have a challenge, or the next barrier for us to kind of come into is to figure out how do we address trusting Gajen's app, right? So I'm running Blue Cross Blue Shield. I want to share my data, with the consumer. Gajen wants to come and say, hey, can I do the OAuth dance with you? But how do I know that I can trust Gajen? Do you think that the TEFCA might help us with that, or what are the tools that we need to put in place next to make that happen?
I'll take a spin at anything, Actually, again, at CMS, some of the work I've been doing, we saw this as a real challenge because you've got issues that we've talked over the last couple of days about things like 21st century cures, where there's this starting definition of information blocking. So one of the things when we were working out how do we approve developers like Gajen and One Up Health to come into our production API, well, the federal government doesn't want to be picking winners and losers, right? So, if we don't do any checks, are we putting our beneficiaries at risk? Which CMS takes that really seriously. So, if we apply too many checks, are we limiting choice for the consumer? Hence, you're on the slippery slope to information blocking. And I actually think the next big challenge that we really have to get together as an industry and address is the issue of what I term developer friction. Gajen, you don't want to go to 1,000 different endpoints and answer the same, 95 of the same 100 questions 1,000 times to get access to an API. We ought to be able to go to a place or two, do the verification once, get some sort of certificate, token, whatever you want to call it, and be able to present that to connect to an API endpoint and present that many, many times. If we don't solve that problem, we're not going to fix the interoperability problem because we'll get stuck at developers wanting to get access to the data.
So Gajen, you were the technical architect on the Precision Medicine Initiative, President Obama's initiative to enable 1 million Americans to donate their data for research purposes, and the NIH was involved. How did you guys architect a solution to that kind of barrier? Did the NIH endorse certain apps, or how did they go about it?
Right. So one of the challenges at the time frame, I was at the United States Digital Service Team. One of the challenges that we faced at the VA at that perspective, VA had about 130 health sites that speak in the different language. In the Vista separate instances, EHR system running, store them data in own way. And the interoperability between these 130 sites, it's one of the challenges that we face in the beginning. And FHIR was one of the important factor that played well in this interoperability problem, where we have FHIR layers sitting on a few different Vista instances within the VA that speaks the same language through APIs. And now if we were to implement that same way across 130 health system, that will be a network of same speaking language sitting on API layer. And that's kind of the route we took to bring in the data in terms of a Million Veterans Program into a one central repository for PMI initiative. But definitely the one of the clear understanding here, it's without that standard FHIR, we couldn't able to get to the next level, or VA to have a EHR vendor that adapting that particular standard, already adapted that particular standard.
We've had a couple of experiments nationally with different standards that would enable trusted exchange. You know, I'm the CEO of the National Association for Trusted Exchange. The standards weren't sufficient for direct protocol, for example. We ran into, you know, from the consumer's perspective, how do we enable consumers to participate as shared decision makers even in healthcare sharing? So standards alone is a big part of it. Where do you see, maybe Adam, you have some ideas around trust frameworks becoming a part of this, or you know, a model like Mark is proposing where we have an infrastructure component that enables it?
Yeah, I think, you know, where FHIR comes into place, right, it's the means for getting access to the data, right? So if you know, we're consumers, right? So how do consumers want to access data, right? Like we're giant nerds, so the three of us brought our laptops because we like our computers. But the vast majority of you like have cell phones, right? And that's the paradigm in which we're now at healthcare, right? So you think High-Tech Act incentivized, you know, 1980, well, maybe I shouldn't say that, but older technology, and we're now in the paradigm of mobile and cloud, right? And so we have to think about how people want to access the data, and in terms of, you know, to Mark's point, we have to answer some key questions, right? So one question is, are you who you say you are, right? Because maybe Gaj is thinking, oh, I want to build an app with Adam's health data. Well, we got to make sure that Gaj isn't getting access to my health data unless I hand it to him.
President Putin might want to do that as well, right? So there's not always good actors everywhere, we've learned. I'm sorry, go ahead.
Oh, no. So I think, you know, leveraging the power of mobile, leveraging the power of APIs, I think is really going to open up a lot of opportunity, and also give patients the ability to look at their own data and say, oh, wait, this account is me, right? So I think a year or two I went to a different hotel chain, right? And so I'm a Marriott Rewards member, and Marriott bought SPG Hotel. And one of the things they allowed me to do through the mobile app is they allowed me to link my account. So now all of a sudden, my points I had with one hotel were now linked to this new hotel. And these sort of paradigms and frameworks of consumer engagement via mobile actually empower me to get my points. So, you know, so I think it'll be interesting to see what sort of motivations, incentives are driving consumers to want to engage with their health information. I think that's probably the big million-dollar question.
And I think one of the folks at the last talk asked about consent and how do we get to a standard consent, and how do we enable consumers to modify their privacy preferences where they are. And you know, have you guys started working on ways to implement those kind of tools in your products?
Yeah, with Blue Button 2, we actually spend a lot of time on how consent would work, and really we ended up turning the advice that the Office of Civil Rights had put out a few years ago back on themselves when we were trying to justify getting the API out the door. And they actually did some great work in clarifying, saying you as a consumer have the right to direct your data to a third party of your choice. So that's part of what we're doing with Blue Button. You can connect the app and send your data to it. The other thing that they said is you as a consumer, as a patient, have the right to actually make that declaration digitally. So you can do it. So we basically argued that if you have logged in with your Medicare credentials, you saying who you are, and now you are connecting an app. So we've done some verification on the app, so they can choose that app and they can give permission to share the data. And I argue that the consent, if you take everything that goes on in that transaction where you're authorizing, you could take that data, that who's the app, what permissions have they been given, for how long, by which person, on what date, and you could put that onto a consent document and you've got consent. So it's an important step in making it as simple as possible. I can't tell you the number. We've had conversations with doctors in doctors' offices about could we send you a paper form that the beneficiary has signed? And now you can let us have the information. And I'm not joking, we were on a conference call, and the doctor had his IT guy on the call, and we said, oh, you can go to bluebutton.cms.gov and look at the documentation. And in the middle of the call, the IT guy came back and said, we don't need to do the paper form. We can just we can create an app and do the handshake.
Correct.
And that's simple. So I think that is influencing a lot of thinking that's going on around consent at the moment.
What are your guys' thoughts?
Yeah, I want to quickly add to a few different, couple of pointers on that. I think that's the foundation that patient-mediated consent is very important. At what we are doing at One Up Health is patient able to connect to about 140 health systems across the country, and patient have the right to select what data is going to be sent out to this longitudinal platform. For example, lab results, medication, they can choose whatever they want to share that data with a particular app of their choice. And those are the incoming data into one centralized platform. And also, one of the points Mark mentioned was the sharing piece also into other apps of choice for other patients. Patients sharing with other providers, that could be one other thing. And when that outgoing connection is happening, patients also able to choose, I want to share certain sections of my lab results, certain medications. I want to share certain things with Stanford Med compared to other provider in different health system. So that's the real consenting that we built in part of the platform, where a true Blue Button enabling patient control the flow. Patient have the right to bring in any app of their choice, connect to a patient portal or to the health system, bring in the data, and then share it with whoever they want to share with.
And it's interesting because I've had a chance to do some human-centered design around consent, and you put forth, here's your rights under 42 CFR Part 2. Is this what you're sensitive to? Is this what you're sensitive to? And we have created abilities to share between covered entities to support those things, but that's not necessarily what the consumers are really sensitive to. But we can allow them to configure their real sensitivities so that it's actually representing their preferences rather than trying to reuse legislation from, I can't believe 1980s or something, right? Like I was still in high school when some of these regs that we still have to try and comply with get flattened when we enable the consumer to get involved. So that, I'm not necessarily sensitive to what you describe as mental health, but I really do care about my IBS. I find it very embarrassing that I have a digestive problem, and I don't want everyone to know. I think that we have to figure out how to, recognize and keep separate the two worlds where we have covered entity to covered entity sharing versus consumer authorization for that sharing. What are your thoughts on some of those conversations, Colby?
Yeah, I think when you take the issue of privacy and just give it back to the consumer, I think that is the right approach. GDPR just went live in Europe and sort of gives an individual the right to be forgotten. And, everyone's preference for privacy may be different. We were joking last night about some of the different privacy folks who attend meetings, and some of them are like, no, I don't want to share anything. And then when I was doing fellowship, one of the ER docs, talked about how patients would just randomly post things to Facebook about things you would never think a patient would post. So, I think rather than, the talk before us talked a lot about policy, right? Rather than letting, the government dictate what the policy is, just give the patient the keys to the house and let them figure out what doors they want to lock or unlock. I think that is sort of a pertinent approach. And what we might find is that, generally privacy may fit into, 3 or 4 different profiles. You'll probably have some people that won't want to share everything. You have some people that want to, one group may want to share everything, one group may not want to share anything, and then everyone else is somewhere in between, right? Like, and you sort of mentioned it, right? I might not care what allergy medicine I take, but if it's some other condition that's more embarrassing, like GI, right? You might not want to share that. Like, so if there's something really embarrassing, like for example, knife. Like I don't tell my mom because she'll tell everyone when I go home. So, so you have to think about who you're sharing with and have that trust.
That trust comes up. TEFCA's out there looming. I think Jeff Livesey kind of described it as mega super King Kong. So if we were the mega super King Kongs for one day, and we could set policy on how consumer sharing should work as far as authentication and engagement, how would you guys sort of start or try to set that policy vector? What are your thoughts on that? If you had the authority, if you were the RCE for a day and you were trying to establish a framework that would allow consumers to be involved in setting their privacy preferences, getting data to where they believe it needs to be, what would you try to encourage as far as adopting FHIR and some of these other apps and so forth?
I'll take a quick spin on this.
I surprised him with that one.
One of the things about FHIR, it's the FHIR resources that's available, like medications, allergies, immunizations, very well articulated into a particular resource. And within that medications, you have certain codings also part of it. And so if a consumer directly consenting at a particular, like for example, medication, I may have general medication, but there's some sensitive medication, HIV medication or something like that. That's very sensitive that when patients are sharing that data with maybe another pharmacy, another insurance company, a life insurance company. So those are the few things that consenting is and FHIR can play a very crucial role in how do we get to that detail level in the weeds, or a resource level like a medication level, or could be at another umbrella level. So I want to kind of leave it there.
Okay. Do you have anything, Mark?
I'd sort of take it back a step. If FHIR is great, and at CMS when I was putting the Blue Button API together, I'm basically lazy and I didn't want to do too much work. So I was looking around and saying, rather than put this data into 15 different resources, then if I'm a developer, how the hell do I piece that together? I actually went to the FHIR community and we actually specified the explanation of benefit resource with them. And now a number of payers are actually using that same resource. So the thing I'd say about that is I think we have to give actual props to the ONC around how they've done sort of standard setting, because if you think about meaningful use and the evolution of meaningful use, nothing actually really says use FHIR. What they said is use APIs, and then they sort of encouraged things like Argonaut to come along and actually say, well, we'll use FHIR. And I've talked to a lot of folks at the ONC, and they're very careful about, they don't want to pick a particular technology because we're going to be stuck with it in 50 years' time. So it's setting that balance of let's point in the right direction, but not say exactly what. And then if you look at, I think the great benefit of FHIR is it really is like an 80% solution. They didn't try and solve every possible eventuality. They basically said, let's take it from an implementer's perspective and what's the basics we need. But then they built in the sort of the extension mechanism saying if it isn't there, you've got a way to add it. And then what we need to do as a community is, as we all think we're all unique. So like if you take Medicaid and talk to a bunch of folks around Medicaid, they're saying how do they want to define certain resources? Well, what we want to make sure is we don't end up with 50 different versions of a given resource, one for each state, because it's going to be 98% the same. And so we need to make sure that even the extensions are similar so that there's less work for developers to do to then integrate, because that's what we need to do, is get more efficient at integrating.
There's also getting more efficient at integrating and improving the user experience. And I would lose my technologist credit if I didn't try to bring in some things like voice computing and some other ideas about how do we make it easier for providers who are in the room, or parents who are observing their children, trying to capture and report behaviors and so forth. What are some of the innovative things that you guys are looking at that might improve usability, actual improved practice and lifestyle of people who are professional healthcare caregivers? Kobe, go ahead. From the HIMSS perspective, what are some of the things that are on the horizon that you think will really improve usability?
Well, I think the way to think of it is thinking new paradigms, right? So we had the keyboard, and then we went mobile, and now we have a new paradigm, I think, with the pervasiveness of voice. So Google just released a thing with their bot that was making phone calls to schedule appointments. Gajen is doing some interesting work with Alexa and leveraging FHIR to get data and interact. So I think there's some really interesting.
I'm not sure about that.
So there's some really interesting opportunities. And that the paradigm of computing is changing, right? So we're on the cusp of IoT, so Internet of Things, right? So multiple devices, everything's becoming digitified, which is basically going to create these data streams, which eventually we'll be able to do some really amazing things with machine learning. But I kind of want to give Gajen a chance to talk a little bit about the work he's doing.
Gosh, please. Yeah, we've got a little demonstration set up. We're going to go ahead and we're going to present the Boston Children's Cerner instance of their EMR on the screen, and then we're going to demonstrate how a physician will be able to interact using voice with his EMR. If we can get the AV guys to bring it up.
Yeah.
Here it comes.
I think it's coming up. Okay, great. Yeah, wait for us a few seconds. So just to give a little background, one of the things that we mentioned a little earlier, and the previous speakers also have a very common theme. We have a lot of information vomit on our face, a lot of information coming out of our face, HL7, different routes, and a lot of information coming from disparate data systems. And how do we make understanding of that? And to minimize clinical burden and improve patient-doctor time. So one of the demo, one of the focus point at Boston Children's, what we are trying to leverage. We have one of the top EHRs in the country. We have Epic and Cerner in-house solution, and we just went live the Cerner to a remote hosting operation, but we use two of the EHR cohesively to serve our patient population. And most of the time, clinical providers spend a lot of time bringing up the patient sign-out report, rounds report from their pockets and try to note down what's going on with this particular patient before they walk into the room or while in the room, inpatient setting, and a lot of time spent on EHR, finding the right clinical note. How do we document back? How do we save the draft? And then finally spend like 2 hours to summarize the scenario, what really happened to the patient. So just to give that's kind of the background of what this demo looks like. So definitely some disclaimer here. Amazon Alexa is currently not a HIPAA compliant. We are using the technology for proof of concept. And so what you're seeing here is Cerner Millennium.
Just real quickly, is the doc who presented yesterday about how to get docs engaged still here? Because this is really, I'd love to get his response and, interact with it, see how this encourages. Are we in the right direction? He's not here today. There's other docs here who can tell us if they like this or not.
Great.
Go ahead, Gosh.
Awesome. So let's give it a spin to this. So bear with me for a live demo. Alexa, ask health records.
Hi there. Welcome to Boston Children's Hospital Health Records. How can I help you?
Get patient demographics for 10002704.
Following is the basic patient demographics for 10002704. Name: Smart, Timmy, male, was born on February 19th, 2012.
Get medications.
I found 8 active medication orders for this patient. Dextrose 2.5% with 0.45% NaCl 1000 milliliters. Captopril 12.5 milligrams oral tablet. Insulin glargine, insulin regular, Humulin R 100 units per milliliter injectable solution. Prednisone, deltazone.
Get labs.
Here are the top 5 labs. Hydroxybutyrate, 0.6, sodium level, 34, glucose level, 102, UA glucose, 3, glucose level, 112.
So he's still trying to log in, and he's already been able to use a stack of technologies, which I hope you'll describe.
Yeah.
Do that verbally.
Right. So what's really happening behind the scene is how do we have a conversational? When the doc walks into a patient room, doc shouldn't figure out how do I sign into, normally as a lot of providers, clinicians in this room, normally when you walk into the room, you have Epic Hyperspace login or PowerChart login, something very similar to that. Doc have to enter their credential, look at their patient list, and choose the right patient, and then spend a little time to get to the right labs section, document section, figure out what it is. So having these data, we already have the data, we already have the know-hows, clinical know-hows, we already have the patient contacts. How do we use AI to authenticate the user, authenticate the doc, load up the right patient encounter, right patient sections, and have voice to help you in the clinical workflow? That's kind of the overall demo of what we have here.
And you know, when he shared with this demo with me this morning, I was thinking about my own experience with my son. You know, I get to see a psychiatrist with him once a month, and he's spending the first 7 minutes trying to pull my son's chart when I need him to be observing my son's behavior. So this will give that doc a few minutes back, hopefully, where he can get the current meds, allergies, whatnot, without disrupting his ability to observe the patient, which I think is going to be hugely valuable. I could hog these guys all day, but I wanted to try and give everyone an opportunity who might have some questions to pose some really challenging questions to these guys and see if we can make them squirm.
I just wanted to say too, I think it's interesting to, you know, when you think of the paradigm, right? So I think technology should be empowering for doctors. It shouldn't be something that's taking away from patient interaction, right? And that's a good friend of mine in Michigan. He's really visionary, and he talks about, you know, like the patient-physician interaction is actually the key to actually fixing a lot of healthcare, right? And surprisingly, like a lot of the work we do with interoperability, the key is to be able to have interactions and talk, right? So interoperability begins with people. So I think it's important to see how this new paradigm of technology should be empowering to the end user.
Yeah, like when have we achieved interoperability is when we aren't talking about it anymore, right? Yeah. It's just happening. We're doing our jobs. We're providing care. We're being empathetic. We're not trying to work around things that slow us down, like a consent form, or logging into another app to access data. Mark, you had some thoughts?
Well, yeah. One of the things when I started out on the Blue Button project, I had people approach me and say, "Are you going to produce like a diabetes app?" And I said, "Absolutely not." And I've talked to other folks around the government. They said, "We really, as the government, we pretty well suck at user experience and user interfaces." So let's let the folks that really do it well, and what we'll focus on is releasing the data under the control of the patient. And that's really what we've done. So we're really trying to create the environment where, the patient can choose. So we've already got applications live on our API where there are effectively clinics that are doing check-ins for Medicare beneficiaries, and those beneficiaries are choosing to share their claim history with that provider. So now they can start dealing with what's the right care plan for that patient, and they're getting that data basically instantly. We're updating our Part A and B information on a weekly basis. So if you are an ACO, you may see that data flowing through, the traditional monthly download, probably about 8 to 12 weeks later, right? So particularly if you think about someone's diagnosed with renal disease, and you get them into dialysis, you want to get them stabilized. I'm not a medical expert, right? So I'm happy for anyone to pick fault here. But if you've got data right at that point of their coming into the program, you can tailor that program rather than just winging it, using your expertise, and then finding the history coming in 2 months later. So we have the ability to really change the way care is delivered by really engaging the patient.
Amazing.
Right. So one of the points that I want to kind of leave you with, it's the earlier point Mark mentioned a little earlier, how ONC plays a crucial role in kind of level setting. Could be standard, but let the industry choose it. So with that foundation, ACO plays very important factor in shaping up our industry. The value-based payment model is kicking in, and as a provider like Boston Children's, we are looking for a way to suck in all the data from externally from patients. How do we keep patients at home healthy, and how do we also improve revenue as well, from telehealth solution to AI, to figure out how do we get all the remote patient monitoring data sets into a clinical hand, and when we needed the care to be an inpatient or a patient coming from externally from different countries for complex care services, how do we bring in that data also with the patient, and also to improve revenue on both sides. So I think ACO is the policy now. It's kind of helping all our providers and patient finally putting patient to the center of care. And FHIR is playing behind the scene of transferring those data in and out.
So, it's funny, as just sort of a facilitator of these kind of talks, when I'm up there behind people and I can't see what they're doing, I don't know that they're ready to ask a question. So I can't imagine being a doc stuck in this blinders, kind of figuring out how to navigate my EMR. How do I log out and get this, and how do I do that, and where's this, and I got to call this guy to get a fax of that. So I saw that Colby was sort of reaching to the mic, and then he took his hand down. So I think he has something to say. But if I was sitting behind him, I wouldn't know that, right? And I'd be turning this way, and we would have lost this valuable information he's about to share.
Yeah, I think a lot of the work that we're hearing about here is still infrastructure building. So it's building the core highway system, and so I think it will be really interesting to see what happens when we have high adoption of APIs, and to see what happens, right? So I always, when I give a talk on intro to APIs, I always talk about Uber, right? How they didn't build the maps, they didn't build a payment app, they didn't build a tech, it's a mashup of apps, right? And so as these APIs become available and become exposed, I think the potential is really endless. I think we're really also in the beginning of modern day deep learning is actually relatively new, and we're seeing some really crazy, fascinating stuff, right? Happening with computers being able to teach themselves how to do things, but to be able to do that, we need access to the data, and right. So APIs are the enabler to get access to the data, and it's fascinating to see what Gajen is doing, playing around with this new technology, and which really could be a new wave of interaction. And so I think lots of exciting things in the works, but I think we still have some very core issues we need to solve, right? Patient matching, right? If we can't match patients, it's going to be really hard to do much anything else. If we can't do authorization access at scale, we're not really going to be able to do and leverage the power of the data. So I think we're moving in the right direction. I think the big question is how long does it take us to get there, and what's the killer consumer app that really changes the paradigm? I think those are some key things to think about.
Yeah, I think if we have questions, I'd love to get some questions. Dr. Pletcher has a question and a bow tie on today.
It's my new nurturing self.
The mic's coming.
So my question is, what Medicare's done is fabulous. I mean, making that information available is really exciting. Is there going to be some sort of flow-down expectation that every Medicaid activity in the country is going to do something similar?
I have to be very careful what I say here. If you ever saw the UK version of House of Cards, you may say that. I couldn't possibly comment is one thing.
But
I think if you look at the recent speeches that the administrator's given, I think there's some very clear indications that if you're in the payer world, really they're saying follow our lead. Okay? What I'm trying to get across to people is don't do exactly what we did, right? Because I take the example of, imagine if the VA went and implemented Blue Button 2.0. They have got a mass of clinical data. They should be releasing that as FHIR resources. We, as CMS, we just have claims. It's incredibly valuable. I mean, the pharmacy data, incredibly valuable, but it's just claims. So that the question is, if you are a payer, if you are a Medicare Advantage operation, if you are a Medicaid agency, you've got to solve the identity issue. Can a citizen authenticate themselves so they can control their information? You then have to deal with, can you map the data that you've got and putting it into the right FHIR resources? And the question for you as payers, if you're out there listening, is really, what are the data elements that you want to effectively digitize to help you improve the relationship between you and your member, right? So do you want to be publishing preventive services that they're eligible for free? Do you want to be publishing prior authorizations so that they know whether they're actually approved for that treatment or not? You know, so we don't have that in CMS today. But we should be thinking about that. What's the right set of resources? But I think every payer in the country should be thinking about how could they do Blue Button 2.0? And I think that's really the message.
I would complement that, and it's interesting, you know, chatting with Mickey Tripathi, there's what the you know, federal regulators and other regulators can do to encourage it. You know, and we're getting good messaging from CMS, from my perspective, that they want everyone to do likewise. But I also see, you know, private payers coming to us saying, how did you guys do that? We want to be able to do that. We want to be, you know, more engaged with our membership and help them be better consumers of the care that we help cover. So
Aaron, I should probably say I am not actually a CMS employee, so I cannot actually speak for CMS.
Other questions? Anything? Don.
Hi, I'm Dan Boyle. I'm with Upper Peninsula Health Information Exchange, and you know, we deal with a large geographic area, rural America. So to the patient matching, I applaud what you guys are doing. I think this is wonderful, and I also love the fact that you said that you are encouraging the consumer to be a part of that data matching, because really, who knows better than the patient themselves where they've been and what they've done. On the other hand, it was mentioned there are certain times where that patient may not be a reliable source of what they really want to have or what they want to expose. So have you given any thought, the first part of the question, have you given any thought to having this a tiered system where the patient maybe uses, you know, biometric to, first of all, authenticate themselves, and then there's certain levels of trusted data source informations that can be linked together by those trusted data sources and the patient to make it something that hospitals, providers, payers are willing to accept that health data as truth. And then there's that consumer portion where they want to publicize out to other things or bring in other sources and kind of keep those worlds separate. You have to kind of step through it, and you have to have more authentication or security for those levels. And then my second question is, once you link all that together, how quickly do you get that, the Alexa to work with EHR so that we can get our rural healthcare providers to access the multiple that they have available to them to pull up information?
So I think the first question is right. So it's complicated. I don't think it's very clear, right? So if you think of matching, right? So there's a lot of terms, and probably don't have time to get it, but there's identity proofing, there's authentication, and then there's matching, right? And these things are all different things, right? And so NIST has a documentation, it's I think 806-3, right, on whole different levels of assurance based on you know, assurance and authentication, right? So certainly at a base level, I think it's good to think about how we can engage consumers. I think in terms of trust, there's obviously some issues with allowing me to self-assert I am who I am, because that opens the door to fraud. But I think in certain use cases, it makes a lot of sense, right? So if you think of matching, it's fundamentally a classification problem, right? It's either match, non-match, or I don't know. If I already know something's me and I can pull it in, right, then if you think of the hotel app example, right, it's pretty, right, I can't get access to it without the token of the password of the other account. So I'm able to actually merge it through just using, very standard methodologies, using OAuth and that type of dance. So I don't know that I have a good answer, but I think,
I'll share like with my own experience, right? So as a consumer, I can aggregate my data into an app that I want to, in order to help manage my son's care. In order for me to donate it for research purposes, I've got to escalate my identity proofing, because there's the equivalent of a legal signature in an out-of-band process for me to consent and authorize the researcher to use it that way. So I see the same thing in other workflows emerging, where for the baseline, where we're aggregating data and giving consumers access to it, I think we have a reusable infrastructure that will support that. And I think there's business cases that would support escalating it when it makes sense. I'm a veteran and I want to become qualified for my benefits, or I want to do Social Security benefits. We have ways of calling APIs to escalate that identity proofing using biometrics and other processes that we've actually demoed in Michigan as well. We've run out of time. Do we have one more question? The best question for last is going to come from Kathleen Connors.
Well, I just wanted to
I have time?
build on
Okay.
what you just said. Then Mark and Aaron were both involved with the first FHIR Connect-a-thon that was held on Monday. It was Monday and Tuesday, and the theme of our track was very much what we're discussing here, was the ability of consumers to exercise their right of access, and also to be able to control it at a very granular level, to say only a FHIR resource marked with a security label that says I don't want to share a certain kind of sensitive information with certain people. So I wanted to say that capability is there. It's in FHIR standard. It's also for V2 and CDA. The other thing I would say is, Mark, you and I have had this conversation before, and when you were describing the OAuth dance, in which the consumer was saying that they agreed to let this app act on their behalf, and they were even able to choose certain data. And then you said something about that just checking that they accept the terms of service, or they're going to use this app, constituted a right of access conformant with what OCR has said. Has OCR actually said that they don't need to have some kind of digital signature on that app when it hits a covered entity and wants to get that data? Or is that just something we're assuming for the sake of argument?
Well,
It's
Kathleen,
live with 53 million people today.
I think you've dealt with various government entities, so getting a definitive answer can be quite challenging. They haven't turned us down, but we haven't necessarily got the absolute stamp of approval. So I think it's really just we're really building on the advice that they've given in clarifying the HIPAA privacy rule. So to maybe to just build on one of the questions earlier around this pulling data into these third-party apps, I think that we're going to see things like blockchain come into place, so that we can actually do things like hash the data, get a hash of the data, so that we can prove that it hasn't been changed, because that's going to be one of the next steps in allowing a patient to pass data on, maybe from one covered entity to another that aren't otherwise connected,
Solving the
and
problem.
helping to build the confidence that providers can trust the source of the data.
Other questions? Oh, he's closed his computer. That's a sign that. Yeah. We have 5 more minutes. Anyone else have any other questions? Because I have some burning questions. I think Dr. Pletcher has one more question. So is that ready to ship? I mean, I'll invest if you're ready to go.
Definitely. I think So I'll give you an example of the industry, right? Look at Apple offering their employees with their health program, and that's one of them. And Amazon, Berkshire Hathaway, and everybody teaming up, these big tech giants teaming up into healthcare, and this creating an industry like where technology industry is also coming into healthcare, and it's a clear evidence of that. And some of us users here Amazon Web Services, and every month or every week, Amazon Web Services rolling out support for HIPAA compliant services. They usually normally announcement goes out to whoever signed up for the program, and then now this particular service is HIPAA compliance. And at least every 2 months, there's one new service that we commonly use. It's upgraded to the HIPAA compliant perspective. So to answer your question, Alexa is definitely on their list, and at Boston Children's also, we are partnering up with some of the industry players and some of the EHR vendors to how do we tightly integrate and build it. And make this kind of platform, make it available for the industry, or show the industry this could be possible with your data. So I think having a good competition like Alexa, Google Home is one of my favorite also. They built on a lot of knowledge, but building in right privacy and consent, that kind of GDPR perspective in the US that'll give consumer the rights will be additional demand that I would love to propose.
So another big innovative component that we have that's coming to life that will enable a lot of things. We talked about mobile, we talked about emerging standards, and if we can start talking about platform as a service that will enable mass innovation so that we're not just building apps that can be operated by giants like CMS and Boston's Children's.
Our keynote speaker mentioned about partners, and one of the challenges we'll always have as covered entities is, is this stuff HIPAA compliant? And so maybe you need to just put a slightly different mindset. If you engage the patient, allow them to use their HIPAA right of access, there is no reason why, and I think I've actually seen demos or listened to demos using our Blue Button API with devices like this. So whilst there may be a real timeline around implementing Alexa in a HIPAA-compliant environment for a covered entity, if you could partner with a consumer-facing application that provided that capability and let the patient choose to use it, you could do that today.
Absolutely.
Right. Just one more point I want to add to Mark's point also. Currently, these the AI-enabled voice services, they send the data, they capture upon a keyword, they send a chain of command or the voice files, and they process them in their neural network clouds. And these neural network clouds also join with other audio chains. They learn from other consumers, other markets, other startups also developing on this, all on the same cloud. So one of the points that we want to demand is voice-enabled platform, it's that containerized some kind of HIPAA compliant services that Mark can send out some of the medication related stuff. We can send out, but this is HIPAA compliance instead of like they're mixing with other non healthcare related neural network engines as well.
So we're disrupting. Oh, here's the king of all disruptors, Tim Pletcher.
Who's going to get in trouble? Who's at risk for us doing this disruption? We spend a lot of time on the legal chain of trust, but there's a lot of complexity available now as we kind of open everything up. We can guarantee that at least one consumer is going to say, "I didn't mean to do that." Who is going to, who's that going to come home to? Because there are some risks in healthcare. It's a pretty litigious environment. How do the big organizations with deep pockets protect themselves from, what is definitely in the patient's best interest, but there are some bad actors. We have bad precedent for people being sued in this space. Who's got a lot to lose by being innovative in this space?
I think some of this comes back to, again, what we're doing is leveraging the HIPAA right of access. So the patient is making the choice. And once they've made that choice, if you want to, I've actually said this, if you want to send your data to a Russian hacker, you are perfectly at liberty to do it, as long as you knowingly, right? So I think we've got to change this mindset. The issue I mentioned earlier about developer friction, we have to get into a network mentality, I think, where we're asking patients to make important decisions about their health data. What data are we giving them to do that? And if we continue in isolation as a data holder, so if you continue to work on your own to say, what apps are we going to let in? Your only frame of reference is yourself. If we develop this concept of like endorsing bodies, then you start to get the network effects of monitoring what are the good apps, what are the bad apps. That's a three-way win. You as a data holder have more points of reference for should I trust this app. It means less work for you in doing that validation process. For developers like Gajen and myself, we only have to do this process once, and we can connect lots and lots of times. It saves us effort. We can spend time on innovating. And for the patient, the consumer, the citizen, they can leverage those endorsing bodies to understand what people are, giving, having good apps, which ones are the bad apps. Personally, if I sort of put my CMS hat on, I would much rather have like Apple or Google validating the apps because they go into much deeper coverage of what's going on in those apps than we can at CMS. And so I would prefer to have something come along and say, this is an Apple-approved health app. I'm not saying they're going to do that, but that would be much better. And so we give consumers a framework for making informed decisions. That's, I think, the only way we're really going to help everybody win.
I think we can, pull from, previous like biomedical research. I wrote a book chapter, 5-6 years ago, and I complained about doing it, but it actually is very helpful now. So if you think about informed consent, does the patient understand the implications of sharing their data? Do they have right to pull that access back, right? I think that would be, and then do they also have the ability to granularly control what data they share? I think having those sort of things in place, which, pulling from, the IRBs and informed consent and a long history of thinking around protecting patients in biomedical research, I think can pretty easily be pulled over. And then I think having some sort of baseline, this may be where legislation could have an effect of setting some baseline expectations of the health app providers, I think would make a lot of sense. But
well, that's where the ONC has actually done work on the model privacy notice, and we, as CMS, we cannot force developers to implement that, but we can actually suggest it, and then you have more of a standardized, way of expressing what's going to happen with your data, which again starts to make it easier for patients or consumers to look at what Mr. Health App are you doing with my data.
Just to take it a little bit away from that conversation and think about it in economic terms, right? In the 1970s, the Fortune 500, 70% of their valuation was based on physical assets, the hospital building, the land that we owned, the number of beds, patients that we were seeing. Fast forward to today, and you look at the valuation of the Fortune 500 again, and it's almost like 85% is based on the information assets that you have. So people who are not disrupting themselves will remain marginalized as a result, in my opinion. So I think if you choose not to disrupt, you choose not to share, the consumer can't share with you. Your information assets become less and less valuable, your organization becomes less valuable, and you do not prosper. Please, everyone, thank my wonderful crew. Thank you, guys.